CSR is a tough disease. And for some people, it's a glancing blow that they experience once in a lifetime, and for others, it's something that comes back all the time. So CSR stands for central serous retinopathy. Let's start with what we know about it. We know that there's a problem in the choroid. That's the blood supply layer in the wall of the eye underneath the retina, underneath the layer that we have to use some technical terms here, the RPE, the retinal pigment epithelium. It essentially is an elevation of the retina with fluid showing up underneath it that we think is caused by this higher pressure in the choroid, finding small weaknesses in that layer that I mentioned earlier called the retinal pigment epithelium, and it kind of spews fluid through that, kind of like water going through a dam. And then that fluid shows up just underneath the retina, elevates the retina, and the symptoms it causes are typically blurring. And then they sometimes will notice a difference in color. Yellows and blues aren't as crisp, or they'll notice that they're just, things aren't matching up with their other eye. So when a patient comes in with these symptoms, we look at their OCT scans, that's the cross-sectional scans of their retina, and then we analyze how extensive the fluid is, if there appear to be any hot spots. Just from the OCT, sometimes you could see that where the fluid is actually actively leaking through. Sometimes we'll do some additional studies, something called fluorescein angiography or ICGA, indocyanine green angiography, to help us further detail where the problem is. Sometimes the patient's symptoms and signs will go away of their own accord. In fact, some studies show that within 4 months, up to 90% will self-resolve. More often than not, I'm going to observe the first time I meet them, and I'll bring them back at a pretty close follow-up. If it's getting better, I'll oftentimes let it get better on its own, but if it's getting worse, I'm gonna have a lower and lower threshold for intervention. And the gold standard for intervention right now is still photodynamic therapy. That's PDT, also called the cold laser. We have to infuse a dye called Visudyne or Verteporfin into an arm vein and then allow that to sensitize the entire body to light. So you're at high risk for getting a sunburn. We oftentimes will have people swear that they're gonna wear some long sleeves for 3 days. There's a small risk for back pain during the infusion of this dye. I say all that to say that it's very safe. And what the laser does is it basically sensitizes or creates like a small sunburn, if you will, in that blood supply. And then that causes the pressure to decrease. We'll see the choroid thickness diminish, and then we'll see the fluid go away. Around up to 90 to 95% of the time, within a month, certainly within 3 months, we'll see all the fluid or almost all the fluid go away. Using the cold laser reduces the recurrence rate by about 30%, but a lot of folks will recur if we give them enough time. If I have a patient that has a recurrence or some evidence of RPE damage, I don't wait very long to treat. Cold laser is, in my opinion, the gold standard. What we know about central serous is that there are certain risk factors for it developing, but essentially we know that steroids create a problem. Now, oral steroids don't seem to create as much of a problem, but they have been listed. I would say inhaled steroids are again, the worst. And so Flonase is probably the #1 offender in my office. Kind of flies under the radar. Intramuscular steroids create a lot of problems in my clinic. And then topical skin steroids. If my patients are able to discontinue those steroids, oftentimes their central serous retinopathy will melt away, but not always. The #2 risk factor is gonna be sleep apnea. So I recommend to my patients, if they snore at night, get that evaluated. If they're already on a CPAP machine, fantastic, don't stop using it. But I don't go out of my way to get them into a sleep center. I allow their primary care doctor to set that up. Patients that are quote unquote type A tend to be a little bit more detail oriented, live in stressful situations, tend to be higher likelihood for getting central serous. Patients that are pregnant also are at risk, and then patients that have like higher than normal stress hormones, so like Cushing's disease, things like that. This is usually like a new change, pretty sudden onset, and it's happening in somebody who's already detail-oriented. Anybody that's ever been referred to me was referred to me because they're getting a routine exam. They came in to see somebody because something was wrong.